And this is, of course, where the importance of accurate records come into play, because if you haven't got a baseline documented, how are you going to know or be able to communicate to anyone else, a specialist or a consultant, that this has changed?
Hello, you're listening to the Dental Protection Podcast, and this is the final episode in our Case Files series. Today we will be asking how we can learn from missed or late diagnosis of oral pathology, and considering the significant consequences not only to the patient, but to the clinician as well. My name is Dr. James Foster, Deputy Dental Director and Dental Lead for Australasia and Asia. My own background is in general practice and as a trainer of young practitioners and teaching in Newcastle Dental Hospital before joining Dental Protection full-time in 2008. Today I'm delighted to be joined by my colleague Dr. Louise Eggleton, who is an international dental legal consultant for Dental Protection and manages cases in the UK, Asia and South Africa. Louise graduated from Leeds University and gained experience as a GDP in both NHS and private, before moving on to be a senior dental officer within NHS Foundation Trusts in community dental services. She went on to accept the position of honorary clinical lecturer for University of Sheffield and recently obtained her master's degree in medical law. Louise and I are both delighted to be joined by our colleague from Dental Protection, Martin Valt. Martin is a specialist in oral surgery who is seeing patients exclusively on referral for over 20 years for the NHS Trust. Martin also has a master's degree and has been associated with Dental Protection since 2000 and who has been full-time with the organisation for the last 7 or 8 years. It's great to have you on board, Martin.
Thank you.
Now, the consequences of missing a diagnosis can have a severe impact on the dentist as well as the patient. This can often be a result of a combination of several errors by different people, and support for the clinician and the patient in these situations is clearly imperative. Now, Martin, as an initial step, obviously examination of the patient is paramount, and the extent of the examination, the recording of the examination and the process can obviously be extremely variable. Can we highlight the importance of a systems and a process and sticking to that?
Yeah, certainly, James. The important thing is to have a system. It doesn't matter particularly what system you have. You don't necessarily have to have the same system as me or as your colleague in the surgery next door, or the same system as the consultant in the hospital down the road. But you need to have a system which A, you stick to, and B, that you can demonstrate by means of appropriate clinical records that you have adhered to in each and every case.
Yeah, and Lewis, I'm sure you would agree, in Asia, we tend to see paper-written records, and the extent of the full examination often is an omission. And if we have a case about missed pathology, unfortunately, sometimes we are not in a position to robustly defend or find an expert who's supportive of the fact that the examination took place and there were negative findings. As we move towards electronic records across Asia, which is definitely on the increase, have we got any advice to members who are making the switch, and can we highlight the important things to ensure that are considered?
So often making a switch to computer records, it can allow for a system to be implemented because there are certain tabs on your charting and your note making to often include intraoral and extraoral examinations. It will allow you to put in locations or the size, shape, colours, textures, etc. of areas of concern or things you may be monitoring, which is very, very helpful. In amongst that, you can use a template for your records, again, which is helpful. However, you just need to be very careful of falling into any traps where you're using a template, that the records are not generic and that you are specifically making notes for that individual patient and editing and inputting the necessary information.
Indeed, we've seen some cases where the credibility of the records and the record-keeping process have been wholly undermined when you see a BPE chart for an individual who's edentulous, or you are seeing some reference to deciduous dentition in an adult. And it is important that when you do go down the route with electronic records, as you say, Lou, it's important that they're very specific, because if they are undermined, then the credibility of the whole defence is brought into question. If we are identifying a lesion or something of concern, I mean, there is an expression, common things happen commonly, but is there a risk of over-referring, or is there actually a risk of being sensible and referring what we are concerned about? Because picking up one out of many is going to be worthwhile, Martin.
It's difficult to get the balance right, there's no question about that. And whilst we all glibly say that intraoral malignant lesions are common, that's a relative statement. And the typical general dental practitioner, certainly practicing in the part of the world where I practice, is only going to see 2 or 3 perhaps in a practice in a lifetime. So I think if the choice is between over-referring and under-referring, I would plump for over-referring every last time.
Yeah, I would agree. My own experience, I referred somebody for what turned out to be nicotinic stomatitis, and it didn't look right, but they came back a little bit frustrated that I'd sent them in, because I think the impression they got from the hospital that it was fairly routine. And then upon reflecting on it, I felt comfortable discussing with the patient that I was actually concerned about the lesion, and therefore was happy to justify the referral. And after a discussion with them, they were happy to accept that.
I think that's absolutely correct. And in the worst case scenario, it's much better to explain to a regulator or to a solicitor why you referred a patient who it turned out didn't have any pathology, than why you didn't refer a patient who it turned out did have significant pathology. It's important to remember that.
Indeed. And when we identify a lesion, and maybe we may commonly see a cause for that, such as an ulcer on the side of the tongue and a poor margin of a crown, that's a classic situation where we may have seen some amendment to the restoration under review. Now, we have seen cases where that review has been repeated and repeated, and the patient has gone elsewhere. And that always puts the practitioner in on the back foot, particularly if the outcome is not progressed. So what sort of period of observation, from your experience, Martin, is appropriate?
I mean, it's perfectly reasonable for a dentist to use their clinical knowledge and skills and experience to ascribe, for example, an ulcerated lesion on the lateral border of the tongue, say, to the sharp edge of a new restoration or a new crown, or a crown which has recently been re-cemented, and that's absolutely fine. And remedial action can obviously be taken under most circumstances there and then to deal with that. However, you do need to review your patient. You need to review your patient within a sensible time frame. If there's ulceration, traumatic ulceration on the lateral border of the tongue mucosa consequent on trauma from a newly placed restoration, if that restoration is smoothed down or otherwise modified, you would expect significant change to take place, improvement to take place in that ulceration within a few days. So you should be reviewing the patient within 5 to 10 days, certainly no longer than that.
Yeah.
And the other thing, of course, is when you review the patient, actually review them. Actually look at the situation and compare the ulceration or whatever the lesion was to how it looked the previous time. And this is, of course, where the importance of accurate records come into play, because if you haven't got the baseline documented, how are you going to know or be able to communicate to anyone else, a specialist or a consultant, that this has changed? So document it correctly. Even better, take a photograph. We've got stacks of technology now which is readily and cheaply available to all of us, so we should make use of it. It really is a case of pictures worth 1,000 words. Rather than endlessly describing and measuring lesions, take a photograph of the thing. That's the sensible approach, because if you don't do that, what will happen in the end? The patient will remain concerned, or their symptoms will deteriorate and they will go somewhere else. A typical scenario is where a patient has attended a dentist, or sometimes even a series of dentists. They've effectively been politely told to go away, there's nothing of concern. And in the end, often in desperation, they present to their general medical practitioner, who, because they have far less dental knowledge, takes one look at the thing and thinks, I don't like the look of that, and refers them off to an oral surgeon or an oral maxillofacial surgeon. and it turns out that this lesion is malignant. And then, of course, when the dentist is required to explain their management, they're on the back foot from the outset, and all this can be readily avoided by appropriate review and good records.
And indeed, talking of records, recording things, these days we see a lot of scans being performed as well as OPGs. Are we all trained? Are we all comfortable in our diagnostic abilities for scans, for example? And that is an area where there is some concern.
Yeah, I recall when I first qualified as dentist, which is longer ago than I care to remember. It was in the mid-80s, and this was around the time where panoramic radiography was becoming fashionable in practice because it had become cheap enough for at least some practices to invest in. And every man and their dog suddenly bought a panoramic radiograph. And we're largely at this point now with cone beam CT scans, but the danger with cone beam CT scans is the imaging they produce, it's very, very different to a plain radiograph, even that of a panoramic radiograph. I think most dentists would feel reasonably confident in reporting on panoramic radiographs. However, if you've not received appropriate and specialist training, you're simply never going to be in a position to report accurately and comprehensively on a cone beam CT scan, and this gives rise to a number of problems. Firstly, you simply may not know what you're looking at, and errors may be made that normal may be regarded as abnormal, and vice versa. And of course, the biggest risk is that you prescribe and take a cone beam CT scan for one of your patients, and you look at what you're looking at, be it to place an implant or to remove a wisdom tooth, and of course there is some concurrent separate pathology glaring you in the face, which doesn't get diagnosed simply because you don't have the training and the skills to do it. So it's very important that if you don't have those skills yourself, that you employ the services of someone who does have the skills to report upon a cone beam CT scan. Because if you prescribe such a scan but fail to identify, for example, a malignancy on there, you're going to be in a vulnerable position should you receive any form of challenge, be it a legal challenge or be it a regulatory challenge subsequently.
And indeed, I think some concern that if colleagues across many countries are doing more of these scans, that there's a danger of a perception that everyone is doing it, so it's okay. In terms of the clinician themselves focusing upon the mouth, there may be distractions and our focus might be taken to other areas. Our mind may not be on the job. Some of those distractions, other work to be carried out, Martin?
Yes, I mean, there are lots of scenarios where it's easy to understand how things have been overlooked. Patients present focused largely on one issue, for example. If a patient comes to see you and all they are interested in is you replacing their quite old and no longer particularly aesthetic upper anterior crowns, then it's very easy for a full mouth soft tissue examination to kind of slip through the net and you think, oh, I'll do that next time. Equally, you can simply be busy and rushed off your feet. You can be tired, or you can be hungry, or you can have had a blazing row with your partner before you left for work that morning. There are a myriad of reasons why a thorough intraoral soft tissue examination may not necessarily be undertaken, but you do need to be in the mindset that at any point that you are expected to undertake a full dental examination, which is pretty much anything other than an emergency examination, the soft tissue examination is part of that. And not only should you do it, you should document it such that you can demonstrate precisely what it is you've done.
And we do have further information around record keeping and processes and a tick box approach. In fact, we often refer to the airline industry as an area for checklists, making sure we've got systems and processes in that we can adhere to and fall into a pattern to, just as you're describing. And Lou, just coming to you, when we've seen members who've had cases where some significant pathology has been missed, maybe a squamous cell carcinoma has developed, we see challenge. Often there's compensation sought and maybe a dental council case as well, and the impact on the member can be of huge significance.
It really can, and we have seen that with a claim for compensation. When that's come in, the patient is obviously upset this has happened. They themselves or the family are perhaps seeking loss of earnings, and on top of that, the patients also wants to stop the situation happening again, perhaps, and has made a complaint to the dental council to highlight the problem and the concern that they may have for the dentist. And on the other hand, we have the dentist who is devastated by the situation, and it's impacted them in a way that we can perhaps consider them as the second victim in the situation, where it's caused a loss of confidence, they're doubting themselves, and obviously they do feel awful that this has happened to another individual for their patient and what they're enduring. So on reflection of supporting the dentist through this as well, we do have a counselling service that provides support 24 hours a day, 7 days a week. Face-to-face counselling can be arranged near you if you do need to seek it, and it's independent, confidential, and can just help the dentist really manage how they're feeling through that situation, on top of if they're having to manage potentially a claim for compensation and a dental council case in relation to it.
Thanks. And with such an emotive subject and situation, if there has been an omission on behalf of the member and the records reflect a story where there's going to be criticism, we have on a couple of occasions seen professional suicide where the individual, and by that I mean the individual then going on to unfortunately cause the destruction of their career by amending the records because they feel so driven, so challenged that the records are falsified, and that has come out at a later stage. And therefore, on top of the actual challenge about missing diagnosis, there's then a question of dishonesty. And unfortunately, in those circumstances, there is often just the ultimate sanction applied by a dental council. So whatever the scenario is, whether it's oral pathology, whether it's any situation, always ask members, please do not panic and start changing records. It pretty much always comes to light, and that is inviting the most significant consequence upon one's career.
If I can just add something to that, James, if you don't mind, I'd just like to make the observation that when records which have been amended for whatever reason appear in front of us here at Dental Protection, 99 times out of 100, it is always blindingly obvious that has happened. And if it's blindingly obvious to us, then it's blindingly obvious to a solicitor or to a judge or to a regulator.
Yeah, indeed. It's a good point. Thank you, Martin, for joining us today and for those valuable contributions. Likewise, Lou, thank you very much for accompanying us today. And I hope the members have got some food for thought. And please do consider looking for our further educational material on the issues we've been discussing. And with that, we've come to the end of this case file series. We hope you found these podcasts useful and informative. If you're a member of Dental Protection and want to know more about today's topic, please look into the podcast description for further information. If you're new to podcasts, maybe listening for the first time, make sure you subscribe to the channel to make listening in the future easier. You can access this podcast from all major apps, including Apple and Google Podcasts and Spotify. For more information about Dental Protection, or if you are already a member and would like a certificate for listening today, please look for details in the description. I've been your host, Dr. James Foster. Thank you again for listening.